Welcome to the Gastro Girl Podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Garland.
Hello, everybody. This question has been noodling around in my brain, and we've had some questions about this. So we thought we'd bring Dr. David Levinthal on today, who's going to really give us some insight on how marijuana actually affects our gut. Now, Dr. Levinthal is a gastroenterologist who is board certified in gastroenterology and internal medicine. He is also director of the Neurogastroenterology Motility Center, as well as assistant professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Pittsburgh Department of Medicine. So we're so grateful to have you here today. I was so interested in your talk at the recent Motility Conference in Austin. Now, I don't know a lot about this topic, but I know that our listeners have questions, and they've had questions, whether they should be using marijuana to treat some of their GI conditions like IBD, or maybe they're recreational marijuana users and they're experiencing GI symptoms that they may not be aware of.
Right. Well, thank you so much, Jackie, for the invitation to be here. I'm really happy to share some information about cannabinoids and in gastroenterology.
Now, what I find fascinating is it seems that more and more states are legalizing marijuana, whether for recreational or for medical use.
I did a little bit of digging because this is such a moving target. How many states in the United States right now can you obtain marijuana legally? And legal for recreation use. So this is not just medicinal. Currently 23 states, including District of Columbia, Puerto Rico, and 4 U.S. territories, it's legal. So that's a lot of states. We're almost at half of the United States. Legal for medical use in additional 14 states. So the majority of states in this country, you can obtain marijuana for recreational or medicinal use. There is a trend toward decriminalization. There are still some states where it's completely illegal, and we were in one of them, Texas. So if anyone had brought their marijuana to the ANMS conference, they would have been in trouble. So it's I think it's very clear that if you look at a map of the United States right now and where you can obtain marijuana legally, sanctioned for medical or recreational use, I think that would have been inconceivable 25 years ago to have that conversation. So that just kind of really puts a fine point on where we are now. And why are we there now? It's because there's been increasing evidence that there are some benefits to marijuana use. And in gastroenterology, if you think about the symptom profile of a lot of common gastroenterology problems, IBS, nausea, vomiting, inflammatory bowel diseases, these are symptom-driven, nerve sensitivity, immunologic conditions. And it turns out that marijuana and its derivatives, cannabinoids, as a class of molecules, has a multiple pleiotropic targets, all of these systems. And so it's not surprising that there would be a role and a drive for patients to treat themselves even for those symptoms. Now, it's not universally just helpful, and we'll talk about that too, right? So there may be some downsides to use that people might not be aware of.
Well, good. So let's start from the beginning. So what is in marijuana, and why is it such a important drug, if you will, that people are clamoring to legalize and use in medical uses? So what is it, and how does it work?
Sure. Cannabinoids are the global term for active molecules that bind to one or more receptors in our body. Cannabis is a plant, Cannabis sativa, the plant, genus species of the plant, that's been bred for thousands of years. And when you think about medical plants, cannabis is right up there with anything that's been around for thousands of years. And it's been used because it has effects. Cannabinoids, it's a mixture. There are at least 70 or more distinct cannabinoids, likely more, that are contained in the plant. When you smoke it or distill it or use it as an edible, we're ingesting these compounds and they work throughout the body. They're absorbed in the GI tract and then work either at the gut level or throughout our body. So I think everyone in the audience probably is aware of THC, tetrahydrocannabinol, delta 9, tetrahydrocannabinol, as being one of the flagship molecules. And that probably has most of the psychoactive properties of cannabis. But there are other cannabinoids such as CBD, cannabidiol, There's some interest in delta 8 THC as another variant. And then a slew of other compounds that get a little bit less attention. So it's probably really, we're talking about two major compounds, THC and CBD. And those have distinct actions, which we can talk about. So when you say what's in marijuana, it really comes down to what is the THC content, what is the CBD content. And just like any varietal of any plant, that can be bred to have more or less selective breeding. And if you look at the THC content of recreational marijuana that's obtainable now on the street or through legal means, the THC content has tripled in the last 25, 30 years. So again, this is not the same marijuana that was smoked in the 60s. This is potent. And we have to acknowledge that maybe some of the harms that could come from marijuana may be manifested because the concentration is just so much higher than it used to be, no pun intended.
So when we're talking about, let's talk about GI patients for now, and then we'll get into just recreational use and the impact that this could have on their digestive system. What is the impact of cannabis on brain gut function? And would it be the TCH or would it be the CBD? And how do you know what to pick? Would you ask your doctor or should you just experiment?
Right. So I think in 2023, it's a tough answer, right? I need to full disclosure. I'm not like a cannabinoid pharmacologist, and I'm not licensed to dispense medical marijuana. So some of the nuances, I think there is a little bit of trial and error there. If you think about it scientifically, it's a little hard to do studies using THC because it's a controlled substance, and that's a little hard to do like a placebo-controlled trial with THC. It's a little easier to do CBD because it's not as regulated. It's obtainable, and there are some pseudochymical forms of CBD. So there have been some recent studies that have used more of the CBD. So we don't really 100% know. So, but to your point, what are we targeting? So if you ingest these compounds, just to take one step back, how are they mediating their effects? And there are two major receptors, not exclusively two, but two major receptors for cannabinoids, the cannabinoid type 1 receptor and type 2. And there probably are more, but we just don't know them yet. So this really parallels the kind of the story that has unfolded over the last several decades about opiates, right? We knew morphine helped people, but we didn't know how. And it came down to recognizing that our body has an endorphin system and receptors for those. And the cloning of the opiate receptor really unleashed a whole slew of understanding of endogenous systems that use those receptors. It's not like we evolved to eventually use medical marijuana. In us, there are these two receptor systems and endogenous cannabinoids, which are called endocannabinoids. So those are in us all the time. The two major ones are called 2-AG and AEA. So those are like the endorphins for the cannabinoid system, to make the analogy. So what are the roles of those two systems? These receptors are in our brain, they're in our gut, they're on immune cells. They are neuromodulating molecules and immunomodulating molecules. They ultimately are what are called G protein coupled receptors, which are on cells, and when they're turned on or off, regulate cell activity. And that cell activity is not specific to if you're a neuron or an immune cell or so on. So you can kind of see how ingesting marijuana could have a lot of different effects. In general, at the brain level, when one takes in THC, that tends to have an anti-anxiety mellowing effect. And I think most people would feel that. Can make you sleepy. Maybe that's a good thing. Maybe that's a bad thing if you're about to get behind the wheel of a car. So I think we have to acknowledge that there are good things and bad things. Some people get a little paranoid or kind of agitated with THC. So as a gastroenterologist, when I have a conversation with patients, whether or not they should even try something like medical marijuana, we have to acknowledge that, if they've had a past experience with marijuana where they get kind of loopy or don't like the feeling, that might be someone that wants more of a CBD heavy strain, for example, of medical marijuana, where minimizing the THC content. In theory, CBD is less psychoactive, meaning that someone would be functioning normally, yet getting some benefits from the drug.
So for patients, and I love the brain gut connection. And it really makes a lot of sense why something like CBD would, have some positive impact for GI patients, especially those with something like a functional GI disorder or a gut disorder of a brain gut like IBS, where they're feeling a lot of pain in their abdomen, or they're anxious and they're having GI symptoms, they're running to the restroom because that's triggering. So that makes sense. I think our listeners could understand, even if they're not familiar with marijuana and how it could work on the body. What other types, what else does, like, we'll talk about CBD. What other effects could CBD have on a patient with a GI disorder like gastroparesis or liver or something, that's going on with them?
Right. So it's a great question. So to be more precise, what do we know? And I don't think this has really been differentiated between THC and CBD. So I'll just put a disclaimer there. But in the gut, when one is exposed to cannabinoids, in general, actually, some physiologic studies have shown that it slows gastric emptying a bit. And you'd say, well, I don't want that to happen. That would probably make me worse, wouldn't it? Well, it's hard to disentangle an effect on the motility pattern, perhaps at the stomach level, from nerve sensitivity in the gut, and how sensitive the stomach is to stretch and filling. And at the end of the day, maybe on balance, for a disease like gastroparesis, a lot of patients have benefited from cannabinoids, whether it's pharmacologic forms such as a drug called Marinol, medical marijuana use, or other forms of cannabinoids. CBD, there's some small trials that have recently been published on CBD effects in functional dyspepsia. And I think there's some sense that that's could help. We need to know more. But I think the balance is that it helps more than it hurts. I think it's fair to say that motility patterns with cannabinoid exposure tend to be slower if you measure it in some very objective measure. But it kind of highlights that not every disease is purely the motility pattern. We can't ignore the sensation aspect of a disorder. How is it that we come to experience anything that's happening in our gut? Can't ignore that our brain is the final arbiter of every symptom that we ever feel. And so I think, when you ingest marijuana, it's complicated. There probably are effects on the gut directly in terms of the actual physical nature of what's happening, but then it may really blunt the symptom profile, the filtering of that information at the brain level. And I think on balance for functional disorders like IBS, functional dyspepsia, motility-defined disorders like gastroparesis, it seems to be on balance helpful.
So calm stuff down, at least with some of the evidence shows that. But again, everyone could be different. Like you said, some people get agitated, some people get sleepy. So it could be the same kind of thing. You don't know.
Right. I think, being open to trying is, I think, the first step, and not taking a huge dose for the first time ever is probably also good advice. So, kind of starting low and going slow. I hear a lot of people use that phrase, so I'll co-opt that. I don't know if that's trademarked, but start low and go slow. It comes up a lot in this field, and I do agree with that concept, right? Because it's hard to really know how someone's going to react, especially if they're completely exogenous, meaning taking it in cannabinoid naive. If someone's been using, marijuana for some time and say, hey, listen, every time I use this, my nausea is just gone. That's a different kind of setting of having a conversation about, well, maybe we should exploit that. And that's someone who kind of knows how they handle marijuana. If it's an 82-year-old, small person, maybe we go a little slow. So you have to kind of price in who this person is.
So for those who may be listening to this and have no idea, they may be living with a GI condition, maybe they have pancreatitis or cirrhosis, maybe they have chronic nausea or IBD. What are some of the conditions where there's evidence that show that it could benefit?
Yeah. So I want to be as cautious. And so my understanding of the current state of play is that, you mentioned cirrhosis and pancreatitis, chronic pancreatitis. I think there are some concerns that exposure to cannabinoids could have a fibrotic or scarring, kind of promotion activity. Now, the degree to which that happens, how much that's theory and how much that actually does happen, I think is up for a little bit of debate, but there is some theoretic downside to someone with those conditions using marijuana. Is that the case for all cannabinoids? Is it a THC effect or a CBD effect? I think we don't really know. But that is on the list of potential negatives that has come up in most literature reviews about the topic. In IBD, there's been an increasing interest in, so IBD, inflammatory bowel diseases like Crohn's disease, ulcerative colitis, chronic inflammatory conditions of the bowel. Obviously, there are many different types of treatments, but a lot of patients suffer from chronic pain and almost IBS-like symptoms, essentially. Even if they're not having active inflammation, there's kind of lingering effects of just having those conditions. And we're increasingly understanding that cannabinoids can help pain pathways, but also potentially, and this is the intriguing thing, maybe have an anti-inflammatory pathway. I'm not advocating by any means that someone starts smoking marijuana to get off their Stelara or ustekinumab or some other, biologic therapy. But it might be worth having a conversation, especially maybe for milder forms that are under control. It might be intriguing.
I'm glad you raised that point, because we're not saying get off medicine and go smoke a joint. What we're really doing here is, and what we try to do with all of our episodes, is arm patients with information that's evidence-based that they could take to their healthcare provider and have a conversation. And there's no one size fits all. Even in some of the guidelines, the evidence may be, lacking, but in some cases it may be beneficial for a patient. But you don't just say, okay, we're going to do this, and without consulting your healthcare provider, because there are so many nuances to a patient's health journey that it would be irresponsible of us to sit here and say, yeah, go out there and try a gummy.
Exactly. So that, I think is an important caveat, right? I don't want patients to take the wrong message. And I think, what is the role in 2023 right now in terms of where we are in our understanding? I think if someone has a chronic condition that's not perfectly well controlled symptomatically, and you've tried a few other approaches and they are not working, it's reasonable to hypothesize, to bring up, as in the conversation with your doctor, could medical marijuana or cannabis in some form, CBD, is that worth a try? And I think on balance, for a disease like ulcerative colitis or Crohn's, that might be a reasonable thing. I mean, everyone deserves to have the best quality of life they possibly can have. And I just don't see that there would be a huge harm, per se, in trying, especially if there's a refractory symptom. I don't think we'll ever get to the point where we say marijuana is the sole therapy that keeps you in remission, and you just have, I don't think that'll pan out. But for symptom management, we shouldn't ignore any possible tool to help people.
Now, as a gastroenterologist yourself, when you're talking to your patients and they're interested in maybe trying, patients should be open with their provider on what else they're taking, correct? Because there could be interactions. So you want to be really transparent with your provider. There's no judgment, right? You don't sit there and judge your patients. You just want to know, because you can make a better decision with them about what their treatment plan should be.
Right. I mean, I think the judgment issue is an important one to bring up, because I think a lot of patients might be hesitant to go there. And I think most physicians are kind of acknowledge that people do all sorts of things, right? And it's a broader conversation than just cannabis. Herbal remedies across a whole wide spectrum, nutraceuticals in general, special diets. We need to really engage with patients about, what are you trying right now? Because if we don't really understand that, we might be missing patient preferences for different types of therapies, and also interactions with medications we might be giving. So I think cannabis will fit in there. There are some spaces where I do think patients get a little stigmatized, which we can talk about a little bit, which falls under some of the potential negatives of using cannabis too aggressive. This kind of increasingly recognized problem with nausea and vomiting episode, something called cannabinoid hyperemesis syndrome. I don't know if that was going to be a part of our topic.
Yes, it was. It totally was. And I remember reading an abstract during ACG, about 5 years ago, that was a case report on someone that kept taking a lot of showers.
Right.
And, we've evolved that science, over the last 5, 6, 7 years. But do we miss anything for those of us who may have a GI condition? Did we miss anything what we should know about before we get into the potential, recreational use and some of the GI things that could happen to us?
So I think just to be clear what we're talking about when we say symptoms. Nothing's a panacea, right? So when you think about the symptom profile that would even begin to start the conversation about cannabis products, there's really two major classes of symptoms. One is essentially a spectrum of nausea and vomiting. Something very special about cannabinoids that target those systems. Smoking marijuana can really help with nausea. It just can. It's the pharmacology. So not every GI illness is characterized by nausea and vomiting, but some are. And those tend to be upper gut symptoms. Gastroparesis would be one, but not exclusively. Some patients with functional dyspepsia have a lot of nausea. There's even chronic nausea and vomiting syndrome, which is what we call patients that don't have gastroparesis and don't clearly have functional, they just are doomed by having, well, not doomed, but plagued by having nausea and vomiting all the time, constantly, day in and day out, not in a cyclic manner. That exists, and I think we have to think about cannabinoids for those patients. And then there's pain, which is such a broad topic, but pain is debilitating, and cannabinoids can influence nerve sensitivity and influence at the brain level how pain signals are interpreted and ultimately how we experience that symptom. So refractory pain, and when I say refractory, I mean people have tried a few medications, neuromodulator medications. I don't think cannabis will ever be the number one go-to, but it's pharmacologically so different from other medications that are available, things like gabapentin, things like tricyclic antidepressants or other neuromodulators, Cymbalta or duloxetine. If people have tried those and haven't had benefits, that's when I start thinking about cannabinoids, because it's such a different class of an approach, pharmacologic class. So I think it's really nausea, vomiting, and pain. For other symptoms like diarrhea, maybe, but I don't think that's going to ever be the go-to. So there may be some slowing effect, but I don't think that's going to be the main thing. I think it's nausea, vomiting.
So, and patients should definitely talk to their providers and see if that's something that they should be looking into. Now, let's get into the recreational marijuana use and what are some of the digestive health effects that could happen.
I don't want to lump everyone's use in the same bin. So I want to make one nuanced point. When we say, the downsides, we have to acknowledge that there's a difference between someone that every few weeks with their friends on a weekend might have one hit of marijuana in some form, ingested or smoked or otherwise. And that's just not the same as someone who uses marijuana heavily every day, multiple times a day. And there are people that do that, right? So I think the harms are probably clustered more on the very heavy utilization than on any use. So that's just a caveat. Right?
But that's perfect that you clarified that, because that's important.
Yeah, because I think, and that gets me kind of to one point, is that I think as physicians, we really need to make that distinction because, getting a urine drug test is, we're not going to interrogate people. You're there to help them. Marijuana lasts in your system for a long time. So just having a urine positive drug screen for marijuana doesn't imply the use pattern, right? I mean, it just, any use will probably show up. So that's a caveat to saying that, there are a couple of downsides to heavy marijuana use. And one of these is the development, for reasons that we don't understand why any one individual might have this, the development of a cyclic pattern of episodes of relentless, intense nausea and repetitive vomiting, even with abdominal pain. That mimics a disorder called cyclic vomiting syndrome, which can exist totally devoid of any marijuana exposure. sometimes in the context of some marijuana exposure, but not defined by it. Whereas cannabinoid hyperemesis syndrome is this increasingly recognized syndrome in patients that probably have pretty heavy use, to be honest. And that's something that when you think about the number of people in this country that smoke heavily, it's only a small subset that ever developed this syndrome. So it's not like it's guaranteed to happen. And so is there some genetic predisposition? Is there some specific sensitivity? Is it even a different disease than cyclic vomiting syndrome? Is it just a trigger for something that we call cyclic vomiting syndrome? We're still working that out. That's actually kind of a thorny kind of philosophical point about calling this a different disease. Yeah. But the treatment is stopping marijuana for CHS, or cannabinoid hyperemesis syndrome. That's a tall order for people that have been smoking heavily for every day for a long time, because there are some benefits. It may really relax them. They may have a lot of anxiety or some other, mental strife that this helps mitigate, and stopping marijuana brings those symptoms back. And, so I think it's a tall order just to say to someone, stop. So I think it's incumbent on us as physicians to help patients get the resources to try to wean off of marijuana, if that's addiction counseling or psychological counseling.
Now, in your work, do you find that people who use daily and they come with you with vomiting, that they're aware of the connection right away? But this is a good educational tool.
Yeah, it's great. Yeah, I mean, I think there's been a lot of increased in the lay press, honestly, acknowledging that there's this connection. And I think most people have kind of heard this by now through the grapevine. Again, this year, I think it's a lot different than even 5 years ago, with the acknowledgement that there's a connection. I feel like the medical information through the internet and large media outfits, can be helpful, but sometimes it can also be a little harmful. And I think we haven't vetted a lot of that information. I think there is some misinformation out there. And one of the pieces of misinformation is that anyone who comes into an ER anywhere with a vomiting and attack must be a marijuana smoker. And this is where the stigma really comes in. And it's kind of the point that I haven't gotten to yet when we've been talking. But what I hear a lot from patients is that they almost get totally interrogated by I don't want to impugn emergency medicine physicians.
Right.
They're amazing doctors. But I think part of the bias right now is that this must be marijuana, and that we can't really help you much unless you stop smoking marijuana. It may be that it could be helpful to stop marijuana, but not everyone has CHS. And so it's cannabinoid hyperemesis syndrome. And a lot of people smoke marijuana recreationally, but not heavily. And so, if they ask you, have you ever smoked marijuana recently? And you say, well, yeah, like 2 weeks ago. And they say, that's why you have the vomiting now. That may not be correct.
Right. So
I think we have to make that heavy use, occasional use dichotomy. Cyclic vomiting syndrome is defined by, our GI societies. There's a group called the Rome Foundation that kind of defines what is irritable bowel syndrome, what is functional dyspepsia, what is cyclic vomiting syndrome, or cannabinoid hyperemesis syndrome. And CVS is characterized, it's a syndrome, so we don't know why people get it. We don't have a good handle on the why part. But as a syndrome, it's defined by 3 or more of these episodes in the last year, essentially, before diagnosis, for reasons that are not a medical reason that can be identified. And basically, those attacks last less than a week at a time and are truly episodic, separated by at least a week in between them. So, shorter attacks over a course of days, hours to days, separated by at least a week or more. That's cyclic vomiting syndrome. A lot of patients with CVS have migraines, and so that's a supportive feature, but doesn't define it.
Interesting.
Then there's cannabinoid hyperemesis syndrome, which is superimposed on CVS, same exact symptoms, just in the context of a marijuana use. The problem with the Rome criteria as it currently stands is that it's not really quantified. What is an excessive amount of cannabis use? I mean, that's kind of subjective, right? My version of excessive may be different than somebody else's. So There's a movement to try to add a little bit more precision and specificity to the frequency and duration in which someone had smoked marijuana. I say smoked, but consumed cannabis prior to the onset of this type of an illness. And if someone never had any vomiting attacks and then started heavy use for a year or more before the onset, that sounds kind of like CHS, cannabinoid hyperemesis syndrome. And the treatment is essentially stopping marijuana. Now, you mentioned hot showers, which is recognized for quite some time as a behavior that patients classically with CHS undergo during an attack. It seems to help mute and maybe even abort the attack. I don't really know how that works. I mean, it has to be, it's not hot water on your feet. It's not hot water on your face. It's on your trunk. So if people take a shower, but it's often like a hot shower on your back or on your front. I can get into a theory.
No, I was going to ask you, is it?
Yeah.
So I'm going back to the motility. When you think about, when you mentioned on our previous point that for it could slow motility, right? It could slow motility. So that could lead to nausea, right? Could that lead to nausea?
It could, but if one's smoking marijuana every day and every 3 months you have an attack that lasts for a day, I agree that it could slow motility, but you would have to posit that motility is slowed all the time. Why episodically, right? So there must be something else that's happening.
They eat too much. Maybe they have too much in their stomach.
It could have been a heavier use that time. It's possible. It could be that there's some long-term change in receptors and sensitivity. And, there are just any number of explanations. My theory of the case is that it has more of a neurologic impact. I don't think it's actually, honestly, a peripheral one for these episodic disorders. Someone who's once the attack is gone, they're like, "Where's my cheeseburger? I'm so hungry. I haven't eaten for a day and a half." So it's not this isn't gastroparesis where that's a chronic.
No. But I was like, but when you take a shower, or maybe it relaxes everything.
It could, right? So there's no question that it's relaxing. There's something about extremely hot showers, though. Almost to the point that some patients have even scalded themselves.
Goodness!
That's a little dramatic to say. Not everyone does that, but it's just that to get the therapeutic effect, we're talking pretty hot temperatures. So we don't really know. I guarantee you that there's some relaxation. Yeah, sure.
That's interesting.
Is it something about the input of heat on nerves that are in the trunk area of the body that influences input to the central nervous system of organs that are represented in that territory too? It's possible. There's something that happens to our brain with that kind of input. And the interesting thing is that there's an emerging therapy of using capsaicin cream. So again, not a hot shower, but inducing a hot heat feeling on the abdomen to actually abort attacks. And the ERs do this sometimes. And it's not rubbing. Capsaicin is the hot chili pepper. That's the molecule that's in hot chili peppers. It's used for neuropathic pain. It's not rubbing it on your arm. It's something about the trunk. So it's very interesting that area of the body is important for understanding this disease. The sympathetic nervous system is regulated from the thoracic spinal cord. And it could be that having some, kind of sensory input. I know this is getting a little out there for your audience.
It's so fascinating. No, but I'm a nerd too, because the body is such an amazing thing. And, you have all these nerves and neurons and everything firing. And it's just so fascinating.
And that's why I do what I do, right? It's interesting, to think about the GI tract through a neural lens. We can't escape that there are these nerve pathways that are processing things all the time, whether overtly or, behind the scenes. We're not always aware of everything. But I think there's something to that. It's a big clue, right? Because if it was just hot water, for example, that would probably be anywhere in your body. It has to be the trunk, it seems. So that seems like a clue. And the capsaicin cream idea is also very intriguing. So it turns out that behavior is not specific for people that have heavy marijuana users that have these episodes of patients with cyclic vomiting syndrome, probably over half, also do that. And they've even figured out for themselves that helps. It's interesting how a lot of people it's almost like this kind of
Intuitive
intuitive drive. Yeah, it's almost like instinct is the word.
Instinctive.
Instinctive drive to just do this. And even if and later people are like, I read on the internet like other people do that. I didn't even know, like it's the right thing to do, which is interesting.
Yeah.
So that actually can also help cyclic vomiting syndrome. So I don't think maybe more people with CHS do that behavior, but it's not specific. So it's not, to use a jargon term, pathognomonic for CHS. So a lot of people for a long time have kind of asked about hot showers as if that proves that somebody has a cannabinoid related problem. And I would say that that's not true. So that's kind of part of the problem of some of this information getting out there in the lay press and then gets into the heads of a lot of physicians. Hot showers does not equal cannabis is the problem.
That's great that you clarified that for our listeners. Yeah. Now I know we could just keep going on and on, but I wanted to, give you back your day so you can, do what you do best and help patients. And we're really grateful. But in summary, what are your tips for patients, for those patients who may have a GI disorder and are interested in maybe trying some of the CBD or other marijuana forms, and for those who are recreational users and maybe experience some GI issues? Like, what are your tips for both of those sets of?
Okay, gotcha. So for those who are not currently using but are interested and think it could help them, I encourage everyone to speak with your doctor, your gastroenterologist, or your primary care doctor that you've been thinking about this, and what are their thoughts. And I think it's important to share that you're about to try something like that, because if there are side effects or any harms, you want your physician to be mindful. I would encourage people that are really struggling to consider medical cannabis in some form, and especially if nausea and vomiting or pain are uncontrolled, that really could be quite helpful. And in terms of dosing this and what forms, in states that have legalized medical marijuana, there's actually a pharmacist at these dispensaries that can talk to you about your symptoms and maybe tailor the strain of cannabis that you might be offered to best fit that symptom. And I would go low and slow, taking one dose and just making sure how you feel, and that's okay, and then going up a little bit as needed. That probably is the right approach. So for those that are heavy users and are experiencing symptoms, this isn't an indictment of marijuana in general, but maybe for that individual, we have to acknowledge that maybe it's not the right fit. Especially in patients that have a disorder that could be harmed, perhaps like cirrhosis or pancreatitis, we need to be a little cautious and try to find some alternatives. But even then, just reducing the dose might be a good start. So I think we need to know that there are some downsides to this, but some upsides too. And finding the right dose for the right patient is probably the right answer. So.
Well, thank you. And we always stress there's no one size fits all. So everything you said is perfect for our audience. Dr. Levinthal, you've been phenomenal. So grateful to have you on the show. It's been so lovely talking with you. I learned so much. I hope our listeners did too. And we're very grateful to have you. So thank you so much.
Thanks for having me on the podcast. That's wonderful. Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.